Good evening. Thank you everyone for joining us. Our webinar topic today is obesity and IBD. Dr. St-Pierre will be presenting and myself, Marie-Louise Martin, will be your moderator for the night. Next slide, please. We'd like to start with a land acknowledgement. On behalf of the Canadian IBD Nursing Board, we would like to take a moment to acknowledge the Indigenous people of all the lands that we are joining in from today. While we meet today on a virtual platform, we recognize the importance of the lands which we call home. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Next slide, please. CanIBD is a consortium of nurses across Canada working in the fields of IBD and is supported by Crohn's Colitis Canada. Our vision is to ensure people of all ages living with IBD in Canada receive high-quality clinical nursing care within a multidisciplinary team. Next slide, please. CanIBD is committed to improving the quality of life for people living with IBD by providing mentorship and learning opportunities to nurses in Canada, creating opportunities for networking and sharing of best practices, developing and adopting nursing guidelines and standards for IBD nursing care in Canada, and elevating the profile of IBD nursing in Canada. Next slide, please. Today's webinar is being presented by Dr. St-Pierre. Dr. St-Pierre is a gastroenterologist and clinical assistant professor at the University of Calgary with specialized training in IBD. She completed her PhD in macrophage immune signaling, followed by postdoctoral training in mucosal immunology. Her research interests include using point-of-care intestinal ultrasound to better understand the influence of metabolic dysfunction and the role of visceral adipose tissue in inflammatory bowel disease. Next slide, please. We'd like to take a moment to thank our sponsor for tonight's webinar, which has been supported by Lilly. So it's my pleasure to turn it over to the expertise of Dr. St-Pierre.
Thank you so much, Marie-Louise, for a really great introduction. I'm excited to talk about this topic tonight. Let me just increase the size of this. Hopefully everybody can see the slides. As we go through the deck, if you have any questions whatsoever, please feel free to put them in the chat. And at the end of this, I welcome any discussion in your views, how you manage obesity and overweight in your clinic. Does it influence what you do? I'm really interested in hearing how people manage this or not manage this. And certainly if any questions come up, we'll address them at the end. Okay, so the talk today is really looking at the intersection between obesity and immune-mediated inflammatory diseases. This deck was developed and supported by Lilly. And mostly what we're going to talk about is inflammatory bowel disease. So again, this was made possible through sponsorship through Lilly. If there's any discussion of off-label use, I'll state so during the presentation. And then this is just who the scientific planning committee was for the development of this deck, as well as the disclosures from the planning committee on this deck and my own as well. Okay, so let's talk about really obesity and overweight in our patients with inflammatory bowel disease and how this intersects. So the learning objectives, what we're going to talk about today is, well, what is the frequency? How often do we see it? What's the clinical impact of obesity and overweight in our patients with inflammatory bowel disease? We'll talk a little bit about the pathophysiological pathways that link both of these comorbidities together. And we're going to talk about what can we do about it, or what are the management strategies that are there, especially in regards to our patients with inflammatory bowel disease. Quick polling questions, and I guess we don't have a poll set up, but just think in your mind what approximately what proportion of patients with IBD do you think live with overweight and obesity in the clinic that you see? And maybe this will be a good discussion at the end, but think about what you see in clinic. And because we have people across the country, it'd be interesting to share kind of your observations as well. And this is just an introduction and a question to think about as we delve into the epidemiology and the pathophysiology. So with that percentage that you have in your mind, now think about that. So the prevalence of obesity in Canada, just across the board, is about 30%. So that's a BMI of over 30. So as of 2022. That's up from 21%. So 1 in 5, or now 1 in 3, in the last StatsCan polling in 2003. I just put that caveat here that these estimates are just based on BMI, which is really the crudest marker and not necessarily an accurate indication of clinical metabolic disease. Okay, so this is a crude marker, but that's what we have available in our population. And so it's about 1 in 3 in Canada. Now for IBD specific data, we don't have that in Canada. What we do have are studies from multiple cohorts across the world, from Korea to European cohorts to the US. And this is what we have throughout these cohorts. So if we look at the proportion that have a BMI of over 30, or what the World Health Organization would classify as obesity, it's up to a third of patients. So very similar to what we see in our Canadian population. And if we add on overweight, so above BMI of 25, that's up to 60 or 70% in certain cohorts. Now, these numbers, specifically these ones that show up to the 65 to 70%, are from some of the US-based cohorts, mostly in Dallas and Pittsburgh. But even in populations that have less prevalence of overweight and obesity, it's around the 20% mark. So it is quite frequent that we encounter patients with IBD and overweight or obesity. Now, when we look throughout the population, this is just a slide to look at the prevalence across age groups. And there's one notable shift at the bottom of that table when you look at new diagnosis of IBD in our population as stratified by BMI, but as you can see, below 64, especially look at our pediatric cohort, the prevalence of obesity is very low in our newly diagnosed IBD patients. And that probably reflects that pediatric patients need a lot of energy, and any nutritional malabsorption or metabolic expenditure because of active inflammation is going to have very big consequences on their BMI and their growth. And then as you look at the population between 18 and 65, when you compare to the control or our general population, patients with IBD tend to have less prevalent obesity or overweight. But when you go into older adults, that shifts. So older adults with a new diagnosis of IBD tend to have higher BMIs at the time of diagnosis. So that's a very interesting shift in our population. We don't have a good explanation for that, but just to see that at some point there is that shift that we see. Now, why would having an excess of adipose tissue lead to active inflammation? There's a lot of basic science data to support all of this information on the schematic, but just to summarize it in this simple cartoon here, is on the left side, you have lean white adipose tissue. So this would be at typically lower BMIs, and you have certain hormones or adipokines or adipose tissue hormones that promote an anti-inflammatory state in this kind of lean white adipose tissue. When you have increased adipocytes, but also bigger adipocytes, or the cells with this fat storage, then you tend to have a little bit more cellular stress. So there seems to be more reactive oxygen species, that a bit less oxygenation, and then that damages tissue that brings in the lymphocytes, the macrophages. There's a bit more of an inflammatory response. We can see this a lot in the diabetes models of inflammation and adiposity, but we see that increased inflammatory signature. And that also corresponds to a change in those hormones that regulate adipose tissue. So, for example, in the leaner mass, you'll see decreased leptin, which is pro-inflammatory adipokine, and again with increasing weight, you see increased leptin, and that will lead to pro-inflammatory cytokines. And as you can see, TNF-alpha and interleukin-6 are quite involved in inflammatory bowel disease. So it's not a surprise that we do see this state vary with inflammatory states. Okay, one thing about adipose tissue to realize is there's different buckets. So it's not all equivalent. Some types of adipose tissue are more clinically relevant to us when we think about metabolic associated disease. And this is just to highlight those different buckets of adipose tissue. For example, there's the subcutaneous adipose tissue, so just underneath our skin. That's less clinically relevant in our metabolic associated disease. And then what's below the abdominal wall layer, so more just surrounding our gut, is visceral adipose tissue. And this is the one that's been more linked with cardiac disease, liver disease, hypertension, dyslipidemia. This is the clinically relevant bucket of fat here. And it's really interesting and probably not a coincidence that it's right next or really envelops our gut. And part of that visceral adipose tissue, there's a smaller portion, it's called mesenteric adipose tissue. And you may have heard the term creeping fat or mesenteric fat wrapping, which is expansion of this adipose tissue around the gut in active inflammatory bowel disease, especially in Crohn's disease in the ileum. When there's inflammation, there's this reaction and expansion of mesenteric fat around the bowel to kind of insulate it from the microbes in the gut as that gut kind of gets inflamed. And the hypothesis is that it gets a little bit leaky and the microbes kind of come out of the lumen, and that's kind of a response of the body to really envelop that gut to try to protect it. That makes sense, kind of like around an electrical circuit. So those are the different types of adipose tissue that we see in our patients. Now, this adipose tissue varies so much in our patients, and this is to highlight all the things that make this really difficult to study and really understand the role. So one of the things is, obviously, in a patient with an IBD flare, they're in a catabolic state, meaning that they need to feed the inflammation. They use a lot of their energy to really feed that inflammation. That leads to weight loss, especially lean muscle mass. And then after that, you put them in remission, you get them good treatment, and then they suddenly bounce back and they go in an anabolic state. And then they have rebound weight gain. I'm sure everybody in their practice has heard from patients when they wonder about whether, their biologic therapy is actually making them gain weight, but it's actually the fact that we're controlling the inflammation that's making them gain weight, not the advanced therapy itself. And so patients through these flare and remission states will have expansion and also melting away of this adipose tissue all the time, kind of similar to what you see in yo-yo dieting, which we know is not great for the body. And then you add on nutritional quality. We know that our patients with IBD don't have the healthiest diets. For example, patients with Crohn's disease and stricturing Crohn's disease will tend to go and gravitate towards easily digestible foods, refined foods, ultra-processed foods, and kind of avoid some of those high fiber foods, obviously because of certain symptoms. And so nutrition in patients with IBD, there's lots of studies showing that the quality of the diet is just subpar. And there's a lot more ultra-processed foods, which again is not helpful when we're trying to avoid this adipose tissue rebound. And we also know that physical activity is less in our patients with IBD. There's a good study, the BFIT IBD study, that showed that almost half of patients with IBD were physically inactive or didn't get to that threshold of that 30 minutes 5 times a week. And a lot of these barriers are the symptoms that they have: bowel urgency, fear of flare-ups. They don't know whether they should exercise. They're also tired because of all these extraintestinal manifestations that we can see in these patients. So it's a very complex interplay between adipose tissue in our patients with IBD. Okay, now, why does it matter? Why do we look at adipose tissue? Well, first of all, it has implications in quality of life in our patients with IBD. And there's the PROMISE study that looked, so this was over 15,000 patients. This was a survey in patients with IBD, ranking a few different things. So one of that were parameters of quality of life, and then others, which I'll show in the next slide, is our inflammatory states. So in here, when you look at patients with either normal BMI or less than 25, and then you compare them to patients with really high BMI, so class 2 or 3 obesity or BMI above 35, you see that the prevalence of anxiety, of depression, of fatigue, as well as abdominal pain is higher in patients with higher IBD. So it does impact the quality of life. So we need to pay attention to this and think about these accompanying symptoms in our patients with high BMI. In addition, we know that the risk of flare-up or inflammation is higher the higher the BMI. So if we look at in Crohn's disease, if we look at the top two graphs here, we look at the risk of flare-up. And as you can see, the risks of flare goes up as we increase in our BMI, and the risk of persistent active disease as well. So not only does it have implications in quality of life, it has implications on how we're going to treat our patients, how often they're going to flare up as well. So very clinically important. There's also great studies looking at treatment failure, endoscopic remission, and risk of surgery or hospitalization in ulcerative colitis. And as we can see, for every BMI increase of 1 kilogram per meter square, there's increased risk of treatment failure, decreased rates of remission, increased rates of hospitalization and surgery, and same thing for Crohn's, increased risk of flare. So again, clinical implications are real. How about at a system level? What does this do to the health system when we have these patients that are a little bit more difficult to treat? Well, it means more time in hospital for our patients. 3 days extra per year, that's notable. Higher hospitalization-related costs as well, due to not only the inflammation and the increased length of stay, but also some of the complications that are associated with uncontrolled disease, an increased likelihood of preventable hospital admissions, and an increased risk of admission for cardiopulmonary disease. So all in all, from an individual to a health system level, it has implications. When we think about adipose tissue, obviously one of the most important outcomes is MACE, or major cardiovascular events, as these are very clinically important, have a high amount of mortality and morbidity in our patients. And we know that in patients with with obesity and overweight, this will exacerbate certain of these MACE outcomes, such as venous thromboembolism, heart failure, as well as arrhythmia. So not only do our patients with IBD already are at a higher risk of MACE, now you add on an extra layer and an increased risk. This is one of my favorite studies looking at visceral adipose tissue. So again, that bucket that's clinically relevant, the one that's like right next to the bowel, and that's associated with so many of these clinical implications. This is a study by Andres Urer and colleagues looking at the amount of visceral adipose tissue. So what they did is they took patients with IBD, they put them through a DEXA scanner, And a DEXA scanner is the gold standard to look at visceral adiposity. So this study is nice because they don't just use BMI, but they look at visceral adipose tissue specifically. And then they split the population into quartiles. So a lower quartile of visceral adipose tissue to the higher one on the right here. And then they looked across the board at any advanced therapy that these patients were on. And they looked at if the patients achieved the outcome. And so the outcomes are in different colors. So either steroid-free remission at typically like around the end of induction or at 6 months, and then the rate of endoscopic remission. So as you can see, as you progress from the left to the right on this graph, you can see that the rates of steroid-free remission, even early or around 6 months, as well as the rates of endoscopic remission go down with every quartile of visceral adipose tissue. So a really nice way to show that this is important. It has implications also on how our patients are going to respond to advanced therapy. Now, does it have to do with more surface area and pharmacokinetics? Well, it depends. There's a lot of good data on whether infliximab is influenced because it's weight-based dosing. A lot of our patients with higher BMI, it's been shown that they get underdosed. So maybe it's underdosage that leads to some failures, but infliximab tends to be one of the advanced therapies that's more susceptible to failure in our higher BMI patients, whereas other classes a little bit less. So this has been well studied through the literature, not just in IBD, but in other immune-mediated inflammatory diseases. And again, like looking at not just infliximab, but adalimumab, higher BMI increases the likelihood that you're going to need higher doses and higher frequency. Again, looking at kind of across the board at IMIDs, psoriasis, IBD, rheumatoid arthritis, and spondyloarthropathies. Again, when you have BMI above 30 versus controls, your odds ratio of failing an anti-TNF is higher. Now, is that the case for others? Potentially. There's one study on ustekinumab where they looked at serum levels, and it tends to be lower in our patients with obesity, but it didn't seem to be clinically relevant. So maybe less of a dose effect for the IL-12/23s. And there's very little or very limited data on our other advanced therapies, but across the board here, whether it's an IL-23, P19, an anti-integrin, or a JAK inhibitor, there doesn't seem to be as much of an influence of BMI on the chances of on the outcomes here. So this I'll park there because we'll open the discussion at the end, but think of when you have a patient in your clinic, does that BMI affect anything that you do in that interaction with a patient? Do you address it? Do you not address it? Do you think about it? Do you think to yourself, it's going to be harder to treat them? What should I do? What do you do with, advanced therapies that are weight-based? Those are all discussions I'd love to get everybody's input on at the end here. Okay, but now what do we do? Let me just check time here, but we're doing well. What do we do in a patient that has inflammatory bowel disease and also overweight or obesity? What are our options? What do the guidelines say? And where does this intersect? So first of all, is there any benefit to weight reduction in our patients with inflammatory disease? We have very limited good studies to show this. There is one small cohort here of patients with ulcerative colitis and Crohn's disease that went on to a Mediterranean diet, which that has been well studied in IBD, looking at the weight change. So patients going on a Mediterranean diet, which already we counsel our patients if they want to do some dietary therapy, especially more for Crohn's disease than ulcerative colitis. This is usually what I'll typically chat with them about. With this, you get some small improvement in their BMI or decrease in their BMI, more so in the these are the changes here in BMI. They looked at 6 months follow-up, and they looked at clinical remission as an outcome here. And even with a small change in BMI here, this is just like half a point. Going on a Mediterranean diet, they saw a lot of improvement in their clinical symptoms. So whether that's due to the weight change or the diet itself, obviously we can't tease out, but we know that together this is promising. And looking again at if you lose weight even through bariatric surgery, these are very small cohorts. As you can see, the N of the population is here on the left, but it varies from just, case control of 4 to a database study in the close to 500, and then the follow-up varies a lot. But all in all, there seems to be a signal in benefit for weight loss throughout these patients. These were all bariatric patients. But as we know, things have evolved, and these are kind of based on the Canadian Adult Obesity Clinical Practice Guideline that was recently published. So these are the 3 pillars that have been developed through this. The first pillar, and that is very important, is psychological intervention. Not only do our patients with inflammatory bowel disease have increased risk of psychological stressors and comorbid anxiety and depression, if that is active in our patient, going through weight management may not be the optimal time. So you really want to start at the base of the pyramid with making sure that they can engage in this care, that they're ready to make changes, because this is such a huge barrier. It's also such a tough thing to address in our clinic, but depending on your resources, we're very fortunate in Calgary to have access to even cognitive behavioral therapy or even community, but that's at the base of that pyramid in that first pillar. The second pillar is pharmacological therapy, and that everybody has heard about it. You can't open the TV without hearing about one of the pharmacological therapies for weight loss, and we'll go through that and what that means in our patients with IBD. And then there's bariatric surgery that's been around for a little longer. We have some good evidence as well, and we'll go through that evidence as well. And here there's criteria here. We'll go through kind of what qualifies for bariatric surgery and pharmacological therapy as well. Okay, but how do we address it? So depending on if you want to address this or not, this is kind of a nice model. This is the 5 A's model. And this is probably similar to what you've probably done for smoking cessation in our patients with IBD. So asking for permission. Can you ask to the patient whether it's okay to discuss weight? They might not be ready to have that or interested in having that discussion, and that's totally fair. So just asking permission first off. Assessing what their obesity-related risks are. I just said the first slide, BMI is such a crude marker, and it is not the best marker to see whether your patients are really at risk of clinically relevant outcomes from metabolic dysfunction. We do have patients that have normal BMI, but their adipose tissue is higher, and they might be at increased risk versus the patient that has a higher BMI, but actually lower adipose tissue. There are certain calculators in terms of dyslipidemia that we can look at. We can look at family history. We can see if their risk is increased, specific to that patient. So assessing what their true risk is. Advising on health risks. So obviously we can everybody's different, but we can at least kind of go over some of the risks that we do know through these studies. And then if patients are interested, then agreeing on achievable goals and kind of behavioral changes that we can go for to modify that risk, and then helping and assisting, whether that's a referral to an obesity clinic that has all the tools and resources to manage that patient properly, or whether it's just dietary interventions that we talk about, like Mediterranean diet or even lifestyle modification. Those are things that we can do within our practice. This would be how I would approach that in a patient that's agreeable to talk about it. So we talked about those 3 pillars here. They are on a pyramid schema. So at the bottom, like I said, like making sure that they're ready, that psychologically there's no big barriers to address this. That's the foundation. Making sure that their nutrition is optimized, that they get adequate physical activity, All of those things are just that base of the pyramid. And then on top of that, we have pharmacotherapy and then bariatric surgery. I'm going to talk about those two as well. Pharmacotherapy, so lots of insurance plans will cover it if they have a BMI over 27 and an adipose-related comorbidity, or BMI of over 30, although that varies with insurance providers, and it's not always the case, and even renewals are a big issue. And bariatric surgery, BMI over 35 and a related condition, or BMI of over 40. So those are kind of the not just insurance, but also referral and coverage baselines that you need to achieve in order to get those referrals or that coverage. And again, it's important to really state that there's no one size fits all. Patients are individual. We need to think about what their life situation is, what their nutrition interventions. It's quite difficult for a patient that has limited resources to access high fiber, fresh fruits, fresh veggies, high quality protein. Those are all things that we need to consider, but really looking at the individual patient and what fits in their lifestyle is important. What about nutrition? We'll start there at the bottom of our pyramid. There's some overlap with, again, kind of the diets that we see most commonly or talk about in inflammatory bowel disease. Mediterranean diet has the most evidence for it in terms of not only improving, like we talked about, improving quality of life in some of those clinical remissions, but it also can lead to modest change in BMI. So a little bit of reduction there too. So there's an overlap between kind of its effects on IBD, but also on that BMI. And there's this specific carbohydrate diet. So again, like similar amounts of weight loss than the Mediterranean diet, but again, like increased clinical improvement. For EEN, that's not typically a diet that we're going to use in our patients with obesity and overweight. That's mostly more for induction, and especially in our PEDS patients. And then there's the Crohn's disease exclusion diet, again, that has where the purpose is to change that microbiome. But the Mediterranean diet and the specific carbohydrate diet, you could achieve at least some small amounts, but you can also get some clinical benefits. So something to think about when you're looking at that bottom of the pyramid. We have lots of data. I'm sure you've seen that, and there's a really good section on the Mediterranean diet on the Crohn's Colitis Foundation website, which I always invite my patients to go explore. But the Mediterranean diet is found to, like we talked about, reduce IBD activity, helps with, we see objective biomarker changes with it. There are changes in microbiome composition that's still exploratory, and we see some small changes in decrease in BMI, but also improvement in quality of life. And that's for our IBD patients and non-IBD. So when I talk to patients that do have those metabolic risk factors, this is just a good anti-inflammatory diet to be on, whether that it's heart healthy, good for your liver, good for your IBD. This is kind of that base of the pyramid if, in terms of nutrition. I've put in this, we put in this slide. This is a really interesting study. It's time-restricted feeding. So this is a study out of Calgary as well as in the Okanagan. So Natasha Haskey as well as Dr. Rahman led this study looking at time-restricted feeding, or basically for patients to eat within an 8-hour window out of their 24-hour day, so kind of a shortened window, 6 weeks out of 7. So not all week, but they got a day of rest, if you will. But for the rest of the week, they had to eat within that 8-hour window. So one of the things is, and that was 12 weeks, so just early on, small cohort. But what they saw is they did see in the time-restricted feeding group reduction in the BMI, as well as reduction in their clinical symptoms compared to the control group, and especially a reduction in their visceral adipose tissue. And so that was significant. And then with the visceral adipose tissue, those adipokines, so leptin we talked about earlier, it has that pro-inflammatory signature, or it causes it, it's a more pro-inflammatory adipokine, that also was reduced. And that's just in 12 weeks. So this is a quite interesting study, and it'll be interesting to see what the long-term data look like, or whether this is a diet that's going to be interesting to explore more. But again, small population, but promising results. I'll talk briefly about bariatric surgery, but really these are the indications for referral for bariatric surgery. So BMI over 40 or 35 with a comorbidity. Patients with IBD have undergone bariatric surgery, and so there's above 10 studies looking at the effects of bariatric surgery on inflammation or IBD outcomes. There were noted some early complications, so some bleeding, some post-peri-op complications, but they're still on the lower rate. They did see some significant weight loss in our patients with IBD, and then there was a decrease in some of those in those IBD outcomes. So, and there's no signal to suggest that there's increased risk of inflammation down the road. There's one study here looking at over 400 patients with IBD that underwent bariatric surgery as compared with patients with IBD that didn't. And they seem to be at decreased risk of requiring intravenous steroids, as well as advanced therapy. The rest were not significant, but promising results nonetheless. And then pharmacotherapy. So everybody's kind of heard about the pharmacotherapy. We'll go over kind of the different ones and what's out there. I'm sure absolutely you've seen a patient with IBD that's asked you about it. Can I go on it? Is it safe? So this is kind of an important part of this presentation. In this table, these are the ones that are currently approved for weight loss. So we have the GLP-1 receptor agonists, so liraglutide, semaglutide in our IBD or obesity cohorts. We have tirzepatide, which is dual GIP and GLP-1 receptor agonists. Naltrexone and bupropion, which is a different mechanism as well as orlistat that's been around for longer, and the amount of weight loss. So these are all based on RCT data. This is not real world outcomes, but that percentage in weight loss changes from modest to quite significant. And we look at tirzepatide, our GIP, GLP-1, we're approaching, we're in the double digits of weight loss here. We're approaching kind of that bariatric surgery change here, but with pharmacotherapy. So this is gaining a lot of traction, and we see more and more of our patients on this. Just brief slide on where these act. Obviously, the central nervous system decreases that food intake, early satiety. In our patients with IBD, depending on where they are in their cycle of remission and flare, may or may not be something that we want for them. So some consideration there. And they have gut-specific effects. So delayed gastric emptying and the side effects that go from there, again, kind of can muddy the picture with IBD. So these are kind of some of these adverse reactions that we can see in the RCT. So so we have the lipase inhibitor, so orlistat, that's been around for a long time. We can talk about it. I don't have that many patients on this, mostly because of the diarrhea, the oily diarrhea that it causes. But when we look at the GLP and the GIP, GLP-1, again, kind of that nausea, diarrhea, constipation a lot, vomiting, abdominal pain, these can be confounders on it, and we can ask ourselves, well, is this an IBD flare or not? And same thing for the opioid the bupropion naltrexone combination. Again, kind of those GI side effects as well, which can muddy the waters when you're trying to figure out whether a patient is in flare or not. An important note as well is a lot of our patients with active IBD were excluded from these trials. So it's hard to really see what it's like. I'm going to just skip this slide for time and just kind of go over what is the evidence for GLP-1 use in our patients with IBD, because this is probably going to be the question you're asked the most in clinic is, can I go on this? What are the implications? So this is one of the larger studies from Akash Desai, looking through the Trinetics database. So out of 47,000 patients with IBD and obesity, they found, around 400 that were on one of the GLP-1 receptor agonists. And then they looked at and compared to patients that weren't. And they did see a decrease in total body weight that was significant with any of these pharmacological therapies. And there didn't seem to be an increased risk of disease flare. So the overall looked safe. But what we did, and this is with our group, is we did a systematic review and meta-analysis of 14 studies. So this is looking at a lot of patients that were exposed to GLP-1, and overall, what we see is in metabolic outcomes are patients with IBD on one of these GLP-1 or GIP/GLP-1 receptor agonists, they do see some BMI changes. They do see decreased body weight, and that varies from 6 to 15%, depending on how long the study was. And there seems to be a improvement in their HbA1c. So overall, there seems to be a benefit, which is, again, important because these patients were excluded from those RCTs. But about IBD outcomes, these are all retrospective, so none of these are looking at really great quality data, but it seems to be that patients don't have increased risk of IBD flares. They have stable clinical indices. And maybe some of the larger studies, there seemed to be a signal in terms of decreased steroid use, hospitalization, and surgery. But again, these are all based on retrospective or database studies. We need more prospective studies. And in safety, there didn't seem to be a huge difference compared to the baseline population. We see the same GI adverse events, notably nausea, constipation, some diarrhea, and those rates were very similar. Okay, and one of the things that in the early days of these RCTs was there was a signal towards potential ileus or obstruction, so that made us pause, especially in our patients with IBD. There's a good study from Israel showing that there's no increased risk of ileus or obstruction in these patients. So again, overall, it seems to behave the same in the general population as in our patients with IBD. Now, looking at the future, we talked about how obesity may promote systemic inflammation, some of these consequences of metabolic disease. Could we harness that and see whether that helps actually go beyond that treatment ceiling and increase our IBD outcomes? That will be something that will be interesting to see. There's the COMMIT trials that are ongoing for COMMIT CD and UC that are pairing our standard advanced therapy, so in this case mirikizumab, with GIP/GLP-1 to see whether, well, one, like I said, we don't have good RCTs looking at body weight reduction in patients with IBD, so that will be already a good outcome to see. But also, do we increase their chances of achieving those clinical outcomes? So that will be very interesting to see, and we'll see at the end. It's estimated 2028. So quite interesting to see. Okay, and then these are just additional questions, but what I'll do is I'll stop it here and then we'll open the door for, open the chat and answer questions, get a discussion going. Very curious to see what people are doing in their clinic. So I'll hand it over to Marie-Louise to see. I don't see any questions in the chat. I don't know if Marissa sees them either.
Thank you, Dr. St-Pierre. That was a fantastic talk. And every time I hear you talk on the topic, I learn something new. I really liked your 5 A's model, the Ask, Assess, Advise, Agree, Assist, because it is something I've kind of struggled with. Like, how do you bring up weight loss in a supportive environment that doesn't come off as non-judgmental? And I've always kind of thought nursing is in a great position to have these conversations because you have a little more time. Because I'm sure most of us have patients who said their family doctor just attributes everything to weight and tells them to lose weight, and then the appointment's over.
And that's very unhelpful for the
Yes,
patient.
consults
That's
is
probably more
judgmental.
harmful to that discussion than, actually sitting down. Yeah, I agree.
So we have a couple of questions now. First one's from Jennifer. Do you typically prescribe the weight loss medications or work with their GPs on this?
Yeah, that's an excellent question. So, myself, I don't. And the reason why is, again, when you address that whole pyramid, there's a lot to weight management that, like within our IBD clinic, we're just not equipped yet. There are, we're looking into could there be a model where we co-manage this because it's so relevant, and that's something that we're working hard on putting together um, at our center with dietitian help and help from specialists in obesity medicine. So I think I would be a disservice to my patients if I was just prescribing it without addressing the whole, um, um, all of the patients' kind of comorbidities, making sure that they get the best weight loss or weight management information and tools for them. So we're looking into integrating that within our IBD clinic. That's still at kind of pilot phase or we're development phase, but we're looking into that because I think overall, as again, like it's a lot of our population. That first slide, like I showed, it's up to 60-70% of patients that have that comorbid overweight and obesity. I think we could do a better job at addressing this, but I think we do it thoughtfully and with all the tools in place. So for now, I do work with their prescriber, whether it's their family doc or at an obesity clinic. And what I'll typically do is kind of just my biggest role is to ensure that they're in remission. So if they want to, so they come with me, they ask me, can I start this GLP-1? I'm like, this is a great time to then let's get some data gathering. Let's make sure that, that your biomarkers are low. Let's make sure that you're in remission. Let's make sure that usually I'll do an intestinal ultrasound, make sure everything's quiet, because if they have some side effects from the medications, I want to know whether this is going to be a flare or not. At least if they start somewhere where they're stable, the chances are lower. And then I'm ready to just reassess that as they have symptoms. So I think our role right now is to really make sure that they're in the best place to start these medications and not muddy the waters. Joan here, is there evidence to support clinical improvement is related to weight loss versus decreased steatosis and improve effect on insulin resistance? We don't, because it's really hard to tease out those two. The clinical improvement, absolutely. I think, when you look at the Mediterranean diet, the weight loss was small, but the effect on the clinical symptoms was high. There's probably more to it, but there's also probably more to just weight loss and weight modification than just mass. Like it has to do, even decreasing adipose tissue will decrease that inflammation, will have some effects on the bowel, I'm certain. So I think all of this is so integrated that's hard to tease out exactly what the individual contribution of these are. But it's going to be, I think we're still in the early phase of really understanding that whole interplay.
There's
Yeah.
a question from Anna. Can you speak more specifically regarding dose modifications for people with IBD and obesity?
Yeah. So dose modification, the evidence that we have, there's good evidence for anti-TNFs that we underdose our patients with higher BMI. They tend to have decreased serum levels. They tend to have lower weight-based dosing than our regular patients. And there's evidence that this is clinically relevant. So they're at increased risk of having to escalate the therapy and increased risk of failing the infliximab. Now, are they failing because we underdose them to start off with? That's hard to tease out. But we know that, especially for the anti-TNFs, it wouldn't be surprising that you need to dose intensify or increase the frequency to capture that. And the flip side is also because they have increased adipose tissue, they might just have more resistant disease and just need more drug for that mechanism specifically. So it's hard to tease out those two. For the rest, like the ustekinumab study, there was lower serum levels, but when they looked at clinical outcomes, it didn't seem to matter. So I think there's something about the mechanism of action compared to its interaction with just BMI. to tease out more so in anti-TNFs rather than the others. But again, the evidence is limited. Would I modify my dose for other therapies based on BMI? Not at this point. I don't have anything to support that. For infliximab, I tend to just regardless of the BMI to either make sure that they're at adequate levels right off the bat. So that's the only thing. I just make sure that they're well dosed based on their weight for the anti-TNFs. That's the only kind of modification it'll do.
Jennifer's next question actually came up in my appointment today. Are there any IBD scenarios where bariatric surgery is contraindicated?
I mean, that will be up to the surgeon. Obviously, if there's active IBD in the upper GI tract, that's going to be not a great candidate to operate on for obvious reasons, for peri-op complications and so on. For the rest, that'll be surgeon dependent, but other than active IBD in that area, not that I can think of, like other than non-IBD risk factors, that would be contraindication. If you're referring patient for bariatric, so kind of on this, like, do you discuss the disease location with the surgeon? And then surgical options, sleeve versus Roux-en-Y. These are all good questions because Roux-en-Y will get you a little bit more weight loss based on the studies. Obviously, a little bit more involved, but it seems to be you get a little bit more weight loss, more effective. The downside, though, and especially in our patients with IBD, is they're already at risk of micro and macronutrient deficiencies, and a Roux-en-Y will potentially exacerbate that. So we see this in our patients with Roux-en-Y with or without IBD, lower iron, decreased absorption of certain minerals. So obviously they're usually followed and you need to be on top of their repletion, especially in a patient with IBD that's at increased risk. So very good question, and something to think about with these surgeries as well. So more permanent, and you get better weight loss with certain types, but also that comes at a cost. Are you aware of sleeve gastrectomy leading to malabsorption of oral medications such as upadacitinib? That's an interesting question. I haven't encountered that, and I certainly haven't seen any evidence for that in the literature. Would it make sense from like physiological level? You may have decreased rates of, you're still going to get some acid production. Whether that has any implication in pharmacokinetics, probably, I can't think of one. Obviously, the place where malabsorption and upadacitinib come into play is more if they're having malabsorption to the point where they're having like high output and diarrhea, and then that becomes a little bit more difficult, and that's where absorption of upadacitinib might be important. But outside of just high output or lots of diarrhea, I haven't seen much in terms of malabsorption in these patients.
Do we have any other questions from our attendees?
These are fantastic questions. Like even the absorption of these medications, there's just so much we don't know. We did publish a case report on a patient on a GLP-1 receptor agonist that her azathioprine level or her mercaptopurine levels completely went out of whack. And she had liver enzyme like elevation because of that. It just probably it didn't make sense from a pharmacokinetic, but certainly like that was the only thing that changed. She was on the same mercaptopurine dose for over a decade, and that was the only thing. But again, like there's just so much we don't know, and that we'll start to see as more and more of our patients are on these medications.
I don't see any other questions in the box. Thank you, Dr. St-Pierre. That was a fantastic talk on a developing topic, which I know we're just going to hear more and more over the years, especially as we learn or acknowledge some of the cardiovascular risk factors of having IBD alone without even incorporating them being on a JAK inhibitor. So thank you everyone for your time tonight. I hope everyone has a great evening. If you're cheering for the Oilers, good luck. And hopefully we'll see you at our next webinar.
Thank you so much to everyone.